Knee arthroscopy, a procedure which has revolutionized the field of orthopedic surgery. But actually, it's quite an old procedure. It started from very humble beginnings about 100 years ago. It was way back in 1910. It was a Swedish physician called as Dr. Hans Christian who actually first developed an endoscope. It used a port of about 10 mm, and it was actually used to view structures inside the gut, which is actually the most of the today's advanced laparoscopic surgery has actually developed from that endoscope. But then it was in 1912 there was another physician called, it was a Danish physician called as Dr. Severin Nordenford, who actually modified this endoscope. From using a 10 mm portal, he went on to use a 5 mm portal actually, and then was also used the same endoscope to view suprapubic cystostomy, and you actually do and view the tuberculous bladder as well. He also used that endoscope actually to view the knee as well, and what is actually inside the knee. From then it was further modified by 1918. It was a Japanese professor, Professor Kenji Takagi, who in 1918 actually modified this further into a 7.3 mm scope, in which he was actually used all this port actually to view the inside of the knee joint, as well as used it to do it for cystoscopy as well. So it was basically the same endoscope which was actually developed by Dr. Hans Christian in 1910, which was actually being further modified into a cystoscope, into a laparoscope, as well as a laparothoracoscope as well. But primarily it was mainly done, what was being done there was mainly just for diagnostic purposes or viewing the inside pathology. When they used to do the knee arthroscopy, they used to view it. If something is wrong, they used to come out and do an open surgery to correct it. So this was what was actually happening before 1980. It was in 1980s, there was another Japanese scientist, Dr. Masaka Wantabe, who developed this interventional arthroscopy, and he can be credited as actually a pioneer of modern day arthroscopy. That is, you go in, you see the pathology, you correct the pathology by with use of an arthroscope, and come out without really opening up and giving it a large incision. So that is how actually it has evolved. It's over the period of time, over 100 years. Then initially there was a single lens system, the normal light source was used. Then they started using a light bulb source as well. Then from that onward, multiple lens system evolved. From then onwards, graded index refraction system evolved. So actually the things have evolved over the period of time of almost 100 years of history to to the kind of a thing we see it today in modern day arthroscopes, especially when you can view it in the case of shoulder and knee arthroscopy. So what is actually the application of arthroscopy in different medicine? In medicine, the indications are arthroscopy can be used for mainly the most important is actually diagnostic surgery. You can go in, see whether there is meniscus is torn, you have an ACL or PCL injury, you have posterior lateral or posterior medial coronary injury, you have a problem with basically the anterior, middle or posterior horn of the meniscus, or which side is involved, or you have a problem with actually the femoral condyles or the tibial cartilage which is actually present on the tibial condyles. So one option best is to just go in there and diagnose what is exactly the pathology is. Along with the diagnostic surgery, another indication for knee arthroscopy is actually the meniscal repair or resection and removal of loose bodies. Now, depending upon whether the problem in the meniscus is in the red-red zone, red-white zone, or white-white zone. If the problem is in white or red-white zone, probably the meniscal resection, which could be in form of a partial or a complete meniscectomy, is a good option. But if the problem or the injury is in actually the red-red zone, then we can go for the primary meniscal repair as well. Now with the advent of modern day arthroscopy, we can not only diagnose it, but once we have diagnosed the problem is with the meniscal tear over there, we can repair it as well as resect it there and then without actually opening up and using an open incision for this procedure. The next is ACL and PCL reconstruction. Now, the important point is over here that there are two different methods of ACL reconstruction, as ACL injury is quite common as compared to the PCL and actually has more indications for reconstruction compared to the PCL. So nowadays, this bone patellar tendon bone graft technique or hamstring graft both can be done arthroscopically, and ACL reconstruction can be performed without actually performing an open surgery. Although it has a long learning curve. Initially, it takes a lot of time to learn the arthroscopy, and just by doing the diagnostic arthroscopy, then a surgeon actually shifts forward of doing it, doing some part of the ACL reconstruction, and eventually will be doing complete of the procedure all by himself. Although it has a steep learning curve, but yes, nowadays ACL PCL reconstructions all in by totally by 100% by arthroscopy is very much possible or is routinely done nowadays. Other options which we can do is, if for example we are suspecting any tumor or any synovial pathology like PVNS or synovial chondromatosis, in that case we can go, instead of using an open incision to get a biopsy, we can use an arthroscope to get actually a synovial biopsy at that time. Then if there is a chondral defect, including there's actually microfracture technique for actually to treatment of chondral defects. If for example at any area of the femoral condyle there is some loss of cartilage due to, and that is actually problematic because that will be very painful, that will result in loss of sort of cartilage from it, and then subchondral bone will be exposed, and that will create more problems for the patient. One way, a technique is that you go in with an arthroscopy and use a retrograde drilling techniques to actually go from this bare area in the cartilage from outside towards inside towards the femoral medullary cavity. And once the medullary cavity contains those pluripotent stem cells, they come and lie over there, they form a fibrocartilage over the top of it. So this is a technique of a microfracture, in which multiple microfractures are being formed at that bare area where the cartilage loss is present. Although this is one option, but other options like autologous chondral grafts, they also can be done by the use of arthroscopy, and if the only it's requires there is no loss of surface there's no loss of cartilage from the surface, then we can also go for some form of a shaving of the area which there is a mild loss of the cartilage. Then osteochondritis dissecans treatment, that is actually the main role of the arthroscopy is the removal of loose bodies. If that body which has actually become loose and is going to travel like a mouse in the knee, that needs removal. Otherwise it will interfere with the mechanics of the knee and may actually damage further other structures. For example, if it gets stuck between the medial meniscus and the medial femoral condyle, then it can damage the cartilage over the medial femoral condyle as well as the medial meniscus as well. Therefore, that needs to be removed by use of arthroscopy. Then knee debridement for osteoarthritis. Although this is nowadays not been practiced, because with the advent of total knee replacements, usually knee debridement for osteoarthritis is actually not an indication nowadays for arthroscopic. But this was practiced at time, because when before that there was some sort of a thought process that instead of straight away going for TKR, you can delay this osteoarthritis by doing the debridement of the knee with use of arthroscope and using lignocaine later on to be infiltrated into the knee during arthroscopy. So that was one thought process, but nowadays it has been made actually redundant, because now the TKR actually mainly replaced the eventually end stage osteoarthritis.